Assalamu alaikum, Dr. Usman Bashir here. Thank you very much, Atiq and Sadaf, for giving me the opportunity to talk about this rather common condition. I have specifically chosen lumbar spinal stenosis because that is where 98% of the problems we face in the lumbar region, although spinal stenosis is the general umbrella term, but since practically we face problems in the lumbar spines, therefore the topic is going to talk about that. So my slides are okay. We're moving forward. So this is the overview, the way we are going to tackle this topic. Topic is quite huge as we delve into that. So overview, we will talk about the clinical anatomy, etiologies, its pathophysiology, which is quite interesting, and some interesting facts about clinical presentation, differential diagnosis, which is again very important, and finally the diagnosis. Now, I think today we will not be able to cover prognosis and treatment part, and that's why I suggest that we hold a part 2 of this talk, because that in itself is a full evidence-based talk, which needs a separate session. So today we are going to talk everything but minus prognosis and treatment. So stenosis, as you all are aware, it's narrowing and it's an anatomical condition in the spine. In the lumbar spine, it can either be in the narrowing of the neural foramen itself, and the most common cause is degenerative arthritis. Most common age group is 60 and above. So a little bit background of the anatomy, basic clinical anatomy, I would say. You're all familiar, you're all pain physicians and anesthetists, so we are familiar with the lumbar vertebra. So if you can see, the canal itself is bounded by the laminae, spinous process, cervical, and anteriorly by the vertebral body and associated. So basically, any of these structures, if they move towards the canal, they will cause narrowing of the canal. So it will be interesting to see that how it happens in pathophysiologically and what goes on to cause this stenosis. The very first process is in the degenerative etiology is the disc dehydration. When there is age-related disc dehydration, desiccation, there is a loss of disc height, and as a result, there is axial loading on all the posterior elements. By that what we mean is the facet joints. So axial loading because of disc dehydration. There is a constant stress on all these posterior elements. Due to that constant stress, they carry on getting hypertrophied, osteophyte formations, and eventually overall narrowing of the diameter of spinal canal. And because these generative processes involve multi-levels, so often what we see in spinal stenosis is polyradiculopathy. Now, this is the initiating process, as I mentioned. And as you can see in the diagram here, this diagram is showing that what would be the possible etiologies of any of these elements which are surrounding the canal can cause a stenosis, thickened ligamentum flavum, herniated disc, hypertrophied facet joints, osteophytes. Any of these things can form spinal stenosis. Second main thing which I'll talk about is one thing was degenerative arthritis, which is in other terms spondylosis. Second etiology related to that is spondylolisthesis, where one vertebra slides over the other either anteriorly or posteriorly, and as a result, the vertebra itself, as you can see here, causes further narrowing of the canal. Often the pars reticularis fractures causes this disability as well, and that contributes to the stenosis. Two other relevantly important things which you need to know from this familiar diagram, which you're all familiar with. The reason I brought this diagram up here in this topic is because two basic anatomy facts that we all know, that spinal cord terminates as conus medullaris between T10 and L2. And most of the lumbar nerve roots are generating somewhere between L2 level as the nerve roots. No, between T10 and L2, those nerve rootlets are coming out as cauda equina, and then they are exiting the respective foramen, as you can see, below L1 nerve root, L2, L3, L4, L5, and then the subsequent sacral nerve roots. Both of these things are relevant as we go further ahead amongst the differentials of the topic. That's why I brought this diagram up here. So amongst etiologies, theoretically speaking, yes, acquired, we have already spoken about that. It is degenerative arthritis or spondylolisthesis. Both of them can cause stenosis, and it is more common in elderly age group. The required causes can be lipoma, synovial cysts, neural cysts, neoplasms. Post-operatively, it could be fibrosis, scar tissue, and other skeletal diseases. So anything which can impinge upon the neural canal, either centrally or laterally, will cause stenosis. Now, for completion's sake, yes, congenital causes are rare, but this is the list which can cause stenosis in the canal. Now we move on to a rather interesting area of pathophysiology. In a nutshell, what is happening is either mechanical or ischemic disruption of lumbosacral nerve roots. So, sorry, just a moment. There is either the mechanical compression or ischemic damage to the nerve roots. The theory regarding the inflammation has not been evidence-based proven. So the compression could be either direct from the mechanical compression itself due to the etiology that we have just spoken about, or it can be indirect with increased intrathecal pressure as a result of canal narrowing. Now, there are various papers which are quite, like I would say in 1990s, most of the papers I'll show you in next slides, which talk about how these things happen in terms of increased intrathecal pressure, which causes venous congestion. And as a result, there is reduced impulse conduction along the nerve roots because of reduced arterial blood flow. And some of the symptoms of spinal stenosis, which are classical, for example, pain, which is exacerbated in erect posture, can be explained by this fact that when you're standing in extended posture, the overall lumbar canal narrows down. And that is because of the overlap of laminar edges, the inward buckling of the ligamentum flavum, and overall rostral and anterior migration of superior facets. All these changes in the erect standing posture causes further narrowing of the canal. So what happens that in already stenosed part canal, when a person is standing upright and walking, their pain exacerbates because the intrathecal pressure increases further. For example, during walking, and the microvascular blood flow to the nerve roots further reduces compared to the demands of those metabolically active activities. So that these two things explain why pain increases in spinal stenosis with the walking or with erect postures. Interestingly, I just looked at the evidence of the papers, and what we found, the papers are quite old, like in 1990s, that This paper talks about the changes in epidural pressure during walking in patients with lumbar spinal stenosis. And what they found that during walking, patients with neurogenic claudication, uh, they had increased pressure in the CSF in the epidural space compared to the normal individuals. And similarly, the increase of epidural pressure at simple walking was much higher than walking with lumbar flexion, which also brings us down to the next symptoms when we talk about the clinical features that in spinal stenosis, the overall symptoms are relieved when you flex forward. There's another paper which is again fairly old, myeloscopic study on the lumbar spinal stenosis with special reference to intermittent claudications. And what they found in this myeloscopic study, again, quite an old paper in 1990, is that there are microcirculatory disturbances of the vessels in the cauda-equina region, which play an important role in intermittent claudication, which is the hallmark in spinal stenosis. So I just thought it was quite interesting to see that pathophysiology-wise, all the studies were quite relatively old. So this brings us nicely down towards the clinical presentation, because we have set up the scene now from the anatomy, etiology, and pathophysiology, that how things are moving towards the symptoms which we see in the clinic and the reason for all those symptoms, which we are all quite familiar with, but I'll just go through them again as a revision for myself and for all of us. The hallmark is neurogenic claudication, or what we call as pseudo-claudication, because it's not vascular claudication. We'll talk about it a bit further in the slides. What is neurogenic claudication? It's a syndrome of bilateral and often asymmetric pain. There is combination of sensory loss and weakness of the affecting legs, and the symptoms are almost always exacerbated by walking or prolonged standing in an erect posture. So this is the classical clinical hallmark of spinal stenosis. And the important feature is the symptoms get better if the person sits down or bends forward at the waist, or while leaning over a shopping cart, or while cycling if they bend forward. So this is also another hallmark of neurogenic claudications or pain related to spinal stenosis. And these findings were actually, again, from quite an old papers that found, basically they looked at a number of case series of patients with confirmed spinal stenosis, that what are the clinical features. Again, a 2010 paper. What they found that neurogenic claudication is present in almost 82% of the patients and is moderately sensitive, and relief of pain by sitting or flexion, for example, squatting, leaning forward, was relatively specific for lumbar spinal stenosis, but overall less sensitive. And the paper concluded that it is the overall combination of these two findings which are most useful for identifying patients who are likely to have the diagnosis. And another positive factor pointing towards stenosis was age more than 70 or more than 60 in some other papers. This paper defines some other criteria as well, that what happens in terms of symptoms, that pain and discomfort with sensory loss and weakness in the legs. Pain was present in 93% of the patients, numbness or tingling was present in 63% patients, and weakness in 43% patients. So that is what we commonly see in the clinical practice as well. Almost 70% patient had bilateral, but often asymmetric pain, and low back pain was in about 65% patient. So this was from a large case series of patients that they defined these rough distribution of symptoms. When it comes to examination of patient with spinal stenosis, surprisingly, neurological examination is quite often normal, and straight leg raise test is present only in very minority of patients. Symptoms of single or multiple radiculopathies may be present, as we talked earlier, that the initiation factor is the lumbar disc dehydration at multiple levels. So that's why often we see polyradiculopathy, and single nerve root is quite uncommon as far as spinal stenosis is concerned. Uh, the cauda equina is uncommon, is rare. However, it is extremely important for us as pain physician to know because there are one, two, or almost three high red flag conditions which we need to be aware of and need to diagnose when we are seeing any patients who is presenting with symptoms of lumbar spinal stenosis. We'll talk about it further when we go into differential diagnosis. So the second main area we talked about in the anatomy part is conus medullaris. So rarely, but it does happen that the site of compression could be between T12 and L1, where the spinal cord is terminating. And in that case, what happens? You get mixed picture of nerve root radiculopathy as well as myelopathy. So, and it resembles more or less same with cauda equina syndrome that you get bowel, bladder, erectile dysfunction, leg weakness, and sensory deficit at T11 or below. An increase in the tone of legs and extensor plantar responses. Again, this is a neurological emergency and requires immediate surgical consultation. So that's why in clinical history and examination, picking up these two high-risk conditions is quite relevant and important for all the pain physicians and even general physicians to know. So from clinical presentation, that brings us nicely towards what could be the differentials. And the most common differential that we talk about is vascular claudication. So the reason for confusing with vascular is both of them are associated with exertional exacerbation. Then how to differentiate one pain from the other? So there, in the next slide, I'll show a nice table which you can take screenshot of or keep for your record. But in a nutshell, what happens in neurogenic claudication, they often persist with the rest when person is standing still in an erect posture because erect posture makes the spinal stenosis worse. However, this is not the case in vascular claudication. When you rest even in erect posture, then those pains get better. Again, in neurogenic claudications, the stoop forward flex posture, uh, even if you're not resting, makes the pain better. Whereas in vascular claudication, if you stoop forward or flex forward, it will not make the pain better. Another differential is, again, not many people cycle here, but if you're cycling in an erect posture, and constantly cycling, the claudication, vascular claudication pain will remain there. Whereas if you stoop forward while cycling, the neurogenic claudication will get better. So the true vascular claudication is relieved in much shorter rest periods and aggravated by lumbar extensions. So all these were the key points to differentiate between vascular and neurogenic claudication. However, sometimes in clinical practice, it is not as obvious, and we have to go down the routes of further tests, which we will talk about. This is a table which nicely summarizes all that which was said in the last slide. You can take a screenshot and keep it in your reference card in your clinics just to make sure that you clinically differentiate and to ensure which patients you will send for Doppler or which patient you will not. Other differentials include non-specific back pain without lumbar stenosis. And because in those pains, we have all seen in clinical practice that even facet pains or sacroiliac pains do radiate down the upper legs, and with walking, they might those pains become worse as well. However, the classic neurogenic claudication is quite unusual, which we spoke about earlier on in previous slides. Polyneuropathy, diabetic neuropathic, bilateral asymmetric pains, paresthesias, numbness, again, can mimic the spinal stenosis, or in sometimes in clinical practice, what you see is that both these symptoms are overlapping. You get a diabetic patient who has also got spinal stenosis. And the reason it is important for us to know that which component will get relieved with our treatment modalities and which component will not. Again, pain of osteoarthritis of hips and knees can also aggravate with walking, and sometimes, quite frequently, the hip pain radiates down both upper legs, and only clinically it becomes sometimes a bit overlapping with the symptoms of spinal stenosis. Other rare differentials are these for theoretical completion's sake, which we can just go down this list and read about it, but they are less common and less frequent. Inflammatory conditions are, again, serious conditions, so that we should be able to pick up, or if we are suspecting them, then again, we should expedite all our workup and referral pathways. Oops. So, having talked about the differentials, now we move on to diagnostic tools. That what diagnostic tools will help us diagnose? Sorry, my. So, as a principle, as we all know and always have been taught, that the diagnosis is not based on the diagnostic imaging alone and must be combined with the clinical picture and neuroimaging studies together, and the context of both should be taken together. Because I'll show you by further studies that there is no relationship between severity of radiological findings and severity of clinical symptoms or prognosis. We have all seen in our clinical practice this common phenomena. Important caveat in radiological findings is that a lot of times spinal stenosis is an incidental finding. That brings me down to this interesting paper, which showed, sorry, the slide is lagging a bit. You all can hear me, yes? I'm still audible?
Yes, sir, we can hear you.
Good. So there was an interesting paper in 1994, which looked at MRI images of about 100 patients without any symptoms, without any pains. And what they found that 52% of the subjects had bulges at least at one level. Almost 40% had abnormality at more than one intervertebral disc level. And that prevalence kept on increasing as the age increase of the subjects. And the findings were similar in men and women. That brings us down to this important fact that radiological findings could be incidental. So always correlate to what you find clinically. And that's why clinical examination history is very important in spinal stenosis. We all know the gold standard test is MRI. X-ray cannot tell us much about the degree of stenosis, apart from the fact it can sometimes give us some hint about loss in the disc height or some osteophytes or facet hypertrophy. Some patients cannot have MRI. In those patients, there is a role of CT myelography as an alternative. Whether to administer contrast in MRI or not, it's a question of if you are suspecting infection or metastasis or the red flags, which we'll speak about further, then you administer contrast along. Some interesting studies which I found that which are looking at even dynamic MRI, and what they looked at the dural cross-sectional area by axial loading in a dynamic way, and found what were the findings in the patients with lumbar stenosis. And they call it DEXA is the abbreviation of the dural sac axial loaded image. And the severity of it demonstrated that the axial loaded MRI is significantly correlated with the symptoms in the patients who had spinal stenosis, which conventional MRI could not detect. However, it is not practical to do these things. These are like studies and research-based data, but I just thought it interesting to show over here. So just a moment. Another caveat in the MRIs and radiological studies is that there is no gold standard fixed criteria to define spinal stenosis radiologically. There are various criteria being used. Some examples use intraspinal canal area. Some criteria use anteroposterior diameter as the criteria. For example, the spinal canal area of less than 76 millimeter square has been labeled as severe stenosis according to one criteria, and less than 100 millimeter moderate stenosis. However, there have been papers in the radiological journals which show that there is significant inter-rater variability when it comes to measuring these and reporting these. Uh, so again, interesting facts from various studies related to that. Sorry, it's lagging a bit. Stuck. My computer is stuck a little, so. Okay. That was just, I was showing you the paper which showed that there is inter-rater variability in when it comes to reporting spinal stenosis. So that is why there is no fixed criteria. So now we move on to other diagnostic tools, because we talked about the differentials, and one of the differentials was polyneuropathy, diabetic polyneuropathy, peripheral neuropathy, which can sometimes mimic or can become a little confusing for clinicians. So for the diagnosis itself, EMG and nerve conduction studies are not required for lumbar spinal stenosis. However, if you're strongly suspecting other neuropathies, then to rule out those differentials, one can do that. Again, Doppler ultrasound, where you're strongly suspecting vascular claudication and want to rule out, or the picture is slightly overlapping and you're not quite sure, you can order Doppler ultrasound studies to rule out peripheral vascular disease. Another simple test is if there is overlap with hip or knee osteoarthritis, you can just order plain films to look at the evidence of osteoarthritis. So this is just ruling out other differentials, or sometimes if there is overlapping picture in the same patient. Most important thing for us as physicians, as pain clinicians, is that we do identify the patients who need urgent diagnostic evaluation and urgent neurosurgical referral. And these are mainly three groups, as we talked about previously: cauda equina syndrome, and one was the other high-risk structural lesion, for example, hemorrhage, neoplasm, inflammation, or infectious etiologies. And third category is if the disc herniation is very severe, associated with quite marked neurological deficit, because all these categories can have a degree of reversibility if timely action has been taken, rather than taking as a routine pathway. So time is short. As we move on to the second part of this talk, then we will talk about the clinical pathway or the approach pathway towards treatment when it comes to which patients are we referring as urgent, which are these three categories, and what are we doing with all other patients. Sorry, my slides are slightly sticky, so it's lagging a bit. Okay. So recap it all. It's a fairly basic overview, but we all had revision about the basic concepts regarding spinal stenosis, that it is caused by a variety of acquired and congenital conditions, but the most common is degenerative spondylosis. The common hallmark is neurogenic claudication. And the main pathophysiology is that either mechanical or ischemic disruption of lumbosacral nerve root function. The inflammation theory is out and obsolete and is proven by the evidence, which we'll talk about in the treatment path. Sometimes in spinal stenosis, fixed nerve root injury can occur and can cause lumbosacral radiculopathy, cauda equina syndrome, conus medullaris syndrome, which is the third high red flag. And the main differential for us is differentiating it from vascular claudication. And we have gone through the details. The main diagnostic study is MRI, However, sometimes you may have to do EMG, nerve conduction studies, and Dopplers to rule out other differentials. So that brings me to the conclusion of today's talk, because I was given 30 minutes. And I don't think so we can do justice to the treatment and prognosis part, because that is a huge area in itself. And I think that demands a separate talk, because there is a lot of evidence which we have to talk about in those talks. So thank you very much. We will now take discussion and questions, but I promise we will cover the treatment part in next session when we get the date confirmed. Thank you.
Thank you, Usman. It was a wonderful presentation. Very
Sorry, let me
absorbing.
turn the sound volume up a bit. Hello, yes,
Can you hear me? Can you hear me?
I can hear you all.
Hello.
Hello, yes.
Can you hear me?
Yes, 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 I can hear you.
But I was saying that it was a wonderful presentation. Very interesting, very interesting. 30 minutes past and 5
Just
minutes.
a moment, I will bring somehow the sound is coming very less. Yes, speak now.
It was, hello, hello. How
Yes.
you can you hear me?
Yes, yes, yes.
I was telling that it took 30 minutes, but it just passed in 5 minutes. It was so interesting, so absorbing, simple, comprehensive, excellent presentation.
Thank you so much. It was very interesting to find these pathophysiological studies which have been done, and the imaging studies and research which has been done when I dig deeper into the topic. So I thought that it is best that we leave the treatment part to the next part of this presentation whenever we decide the date, because that part will generate a lot of discussion and debate, about.
It was a good idea to keep it simple in 30 minutes talk. After 30 minutes, people usually start getting yawning and
Exactly,
boring.
exactly.
Anyway.
But clinically, we see, I think, vascular diseases, somehow I have not seen it that commonly in Pakistan when I was doing practice. So what is audience's experience? Do you see it quite often when you see patients? I saw very few patients who had actually had vascular claudication, which came to pain clinic. And then we found that it was not neurological, it was proper vascular. What is your experience?
There are very few patients I haven't seen, but in my practice, I routinely palpate pulses, dorsalis pedis and posterior tibial in all patients who complain of pain in the legs. You have to exclude vascular insufficiency. Recently, a few months back, a doctor of Gangaram had pain in both legs. It was initially diagnosed as some GB syndrome. Then later on, they diagnosed it as some neurological illness. And finally, when they saw that their both limbs were blue, so there was clots in the femoral areas. And anyhow, she survived the amputation. And, so it is mandatory for all pain clinicians to palpate pulses all patients who complain of leg pain as well, especially in walking.
So I've got a question from Dr. Memoona, that how severe stenosis it has to be for neurosurgical referrals. So we will cover this part very broadly in detail in the part B of this talk, Memoona. The nutshell answer is that if there is progressive neurological deficit and you can see that there is significant stenosis along with instability, so then one can refer to the surgery, but it is not that much straightforward. It depends upon a lot of positive predictive risk factors, or the outcome measures, which there is quite a lot of studies which have shown that which type of factors will have a positive outcome for the surgeon. So we will cover it in our next talk about that. But in a nutshell, if you are facing a patient who has significant neurological deficit, and the patient choice also matters in this, because in the end it is a benign condition. However, if the neurology is progressing, then you do want to safety net yourself and refer to the neurosurgeon. And the main endpoint for us is all those red flag ones, the conus medullaris and syndrome, and the the cauda equina syndrome, and other red flags of inflammation, neoplasm. So those have to be urgently referred. But we will cover that in detail, inshallah, next talk.
Thank you, Dr. Usman. It was a wonderful presentation. My humble suggestion, why not have the second session of your presentation so that we have the sequence in one go?
We have run out of time because I was given half an hour, and when I prepared this talk, then I realized that because that itself has a lot of things to discuss. So, both Atiq and Sadaf then said that, yes, let's do, because that part will have a lot of discussion. We'll put more time because it is going to talk about all the evidence which we have to date for us as pain physicians, and the surgical techniques and a minimally invasive techniques. So because when 30 minutes already passed, but just covering these basics, so I thought it will not do justice if we just squeeze that part in at the moment in this presentation. So inshallah, as soon as the next session is there, we can just discuss about this, so that with that part is quite a lot of bread and butter for us as pain physicians. So it's better to keep us engaged in the topic and come to that, inshallah.
Probably in Ramadan we are not having any session. It will be
So
after
in the start
Ramadan.
of April or just immediately after Ramadan,
Yes.
we can do that.
Yes, yes.
So as you can see that this otherwise we had to just squeeze in and rush into that. So that's why I kept it. And that is quite a lot of papers which we have to discuss in terms of all the studies which are showing whether epidural is useful, not useful. So we have to dig down in a bit deep into the evidence. And I thought this 30 minutes is already full with these overview topics.
If you are
but we'll discuss it in next session. But what I found overall, the evidence which is currently up to date is not supporting epidural steroids for the treatment of spinal stenosis. But all those papers which I looked at and found, they were looking at long-term benefit. So maximum duration that they looked at was 10 months. So if the benefit was less than 10 months, then they deemed it unsuitable or did not favor this treatment pathway. But we'll discuss it in much more detail in next session, inshallah.
Yes, yes.
Sadaf, any other questions from the chats or any other things?
Thank you very much, sir, for your time. We have one more question by Dr. Shahid, and he's asking about if there are any gait abnormality or posture adaptation of the patient who is having spinal stenosis.
Sorry, repeat it again. Your voice is actually say it again. What is the question?
Any gait abnormality or posture adaptation of a patient who is having lumbar spinal stenosis?
Yes, absolutely, absolutely. As I said, if you look into the clinical picture, I'll just show you. You will see that they will prefer the classical sign that they say is the stooped forward shopping trolley posture, they will be forward. They will prefer to stoop forward. Even if they are cycling, they will stoop forward because that relieves the pain. Because when you're erect, as we talked about in pathophysiology, a lot of things are happening in the spine that further narrows down the canal. So when they stoop forward or flex forward posture improves all those supply demand mismatch which the nerve roots are facing. So that is the classical gait or posture that you will see in the spinal stenosis. They will say that when they go into ruku position, the pain gets better. When they sit and stoop forward, the pain gets better. That is one of the hallmarks of claudication symptom as well, so for defining the spinal stenosis. Is that clear?
Yes, sir. I think we don't have any other question in the chat box. So do we have any other comment from the audience? Thank you very much, sir. Thank you so
So
much
thank
for
you
your
very
time.
much. Just due to the shortage of time, I did not want to do injustice to the treatment part. That's why I left it for the next session, and that will keep me engaged with you all and you all engaged with the topic as well. So look forward to seeing you soon, inshallah. Thank you very much.
Thank you so much, sir. Thank you very much, everyone. Inshallah, we'll be announcing our next session soon. Thank you.